Visible? So anyway, H2O and CO2, here is one enzyme which is carbonic anhydrase. This box, small box which we have drawn, this is the parietal cell. Inside this reaction is happening. Carbonic anhydrase is a facilitator enzyme which increases the rightward direction rate of the reaction. The rate of the reaction in the rightward direction is increased by the carbonic anhydrase. Now this carbonic anhydrase will create this H2CO3, it is the carbonic acid, and this H2CO3, I am just elongating the cell over here. Okay. And this H2CO3 is converted into H plus and HCO3 minus. Why we are putting so much pressure on this? Because this is a very common short note. Very common short note that you will face in the exam. Be it trimester, be it class test, even in the prof. Many times if you go through the university exam questions, you will see this kind of questions multiple times. So this is the acid secretion pathway, acid secretory pathway in the parietal cell. Now what happens? Now we have these two. One is this and another is this. So one cation is there, another anion is there. What is happening? On the left side, suppose if we are drawing the capillary, so this is the blood. This is the, you can draw it on either side, no problem. Basically, in it might be slightly different. Major thing is one side is blood, the other side is the GI lumen or gastric lumen. That's the major thing. And we need to produce HCl in the lumen. We need to produce HCl in the lumen itself. So what we have to do, this H plus we need to send it to the lumen somehow. And somehow we need some chloride over here. Now from where this will come? This chloride will come from the blood. Because we know in blood there is one very common anion, that is the chloride. Now what we need? We need this chloride to transport to the lumen. Now how that is happening? This is HCO3, that's an anion which has been formed over here. Suppose if I take this HCO3 over here, and this HCO3 goes back to the blood in exchange of this chloride. In exchange of this chloride. Because chloride just can't enter the cell. This is the polar structure, and this will jeopardize the electroneutrality of the cell. So if we need one molecule of chloride, we need one molecule of another anion out of the cell. Same thing is just happening over here. Since this is a polar structure, tumra cell membrane structure, do you remember? Cell membrane structure, polar structure, tar jodi pass korte hoy, you need some kind of vehicle, cell membrane, because polar structure are not lipid soluble structure. Had it been a fat, had it been a lipid soluble substance or steroid medication, it will simply pass through the cell membrane or the bilayered membrane, phospholipid membrane. But this being an anion, it requires some vehicle, and this vehicle is an anionic exchanger. This AE means anionic exchanger. Okay. Lipid soluble, you can simply go on. Don't mention this when he comes back. Okay, anionic exchanger, and don't stop yourself going outside. Occasionally it happens. If you fill, you may go outside. No need to ask. Anionic exchanger it's a chloride HCO3 exchanger. Very important. এটা কিন্তু MCQ তে আসবে, chloride HCO3 exchanger. ATP লাগে? না। কিছু না। ATP লাগে। Now what is happening here? H plus. What is the luminal pH?
1.3 to 1.8.
Approximately. একটা বইতে এক রকম পাবে, 0.8 থেকে 1.2. Below 2. Basic thing is it is below luminal pH. That means millions of H plus is present in the lumen. Now this H plus simply can't go into the lumen. It requires some kind of push. Only then it can go out. So this push will come from ATP. So we will be getting a primary active transport over here. H plus will only go with the help of an ATPase. And since H plus is going out, another cation should come inside to maintain the electroneutrality. Here comes the concept of H plus, K plus, ATPase, and we finished the class last day here and only, and we called it to be proton pump. So you can expect a short note only on H plus K plus ATPase. So H plus K plus ATPase. So H plus K plus ATPase চলে এলো, এটা হচ্ছে আমাদের বেসিক আইডিয়া। যেটা এখানে মেজর আইডিয়াটা যেটা ভীষণ ইম্পর্টেন্ট টু হ্যাভ আ ওভারঅল আন্ডারস্ট্যান্ডিং অফ হোয়াট এক্স্যাক্টলি ইজ হ্যাপেনিং। হ্যাঁ
বলছি আপনি বলেছিলেন ক্লোরিনটা বাইরে চলে যায় লিউমেনে,
হ্যাঁ
গিয়ে এক্সিট হয়ে যায়, তো তখন ইলেকট্রিক্যাল নিউট্রালিটি কিভাবে মেইনটেইন হবে সেলের মধ্যে?
H plus বেরিয়ে যাচ্ছে।
না স্যার, ক্লোরিনটা যাচ্ছে বাইরে,
হ্যাঁ
তাহলে নেগেটিভ কিছু তো ভেতরে ঢুকবে।
হ্যাঁ নেগেটিভ এই জিনিসটা কন্টিনিউ হবে।
না না, ওই দিকটা ঠিক আছে
হ্যাঁ না না না, এই ক্লোরিনটা যখন বেরিয়ে যাচ্ছে আবার একটা নিউট্রালিটি ডাউন হলো, সো देयर উইল বি আ নিউ অ্যানায়ন ফর্মেশন। অ্যানায়ন ফর্মেশনটা কন্টিনিউ হবে।
আচ্ছা
ক্লোরিন যদি স্টে করে যায় তাহলে আর অ্যানায়ন ফর্মেশন হওয়ার কোনো দরকার নেই। সিন্স ক্লোরিন মুভস আউট এবং পটাশিয়াম যেটা বাইরে থেকে ঢুকছে সেটাও একটা সার্কুলার মুভমেন্ট দেখিয়েছিলাম আগে থেকে। সো দিস উইল কন্টিনিউ দ্য রাইটওয়ার্ড ডিরেকশন অফ অল দ্য রিয়েকশন। ক্লোরিন যে বেরিয়ে গেল তার মানে কি ক্লোরিনের একটা রিকোয়ারমেন্ট ক্রিয়েট হলো, ক্লোরিনের একটা রিকোয়ারমেন্ট ক্রিয়েট হলো। ক্লোরিনের যদি রিকোয়ারমেন্ট ক্রিয়েট হয় আর অ্যানায়ন সাপোজ হোয়াট ইজ কোশ্চেন ইজ বসো বলে দিচ্ছি। So his question is chlorine is moving outside, definitely. Chlorine is going to the lumen. So if chlorine goes out, how the electron neutrality is maintained? It is not maintained instantaneously. Chlorine moves out means there is a decrease in total anionic level. That will lead to generation of more bicarbonate. More anion will continue. So this whole process is a vicious cycle. The more the thing will run, it will lead to more and more rate of reaction, kind of that. K plus is going inside. That K plus will also come out. And that will come back to the lumen. Whenever this will happen, again K plus will come in. So this both things are in a circular. You can mention this kind of wisdom if you can put on your paper, you can get full marks on this. Otherwise, ছবিটা এঁকে চারটে লাইন লিখে দিলে we will still give you 80% and above. What we are doing over here. ছবিটা আঁকলে and লিখলে যা লিখলে 80% and above you can take. But if more wisdom is seen, only then we go for the full marks. Okay. So next is what exactly is happening when everything is combined. So next picture is little complicated. বলবে দেখতে পাচ্ছ পুরোটা। Is it visible to you? তিনটে লেটার যে লিখেছি দেখতে পাচ্ছ? একটা লেফটেরটা হচ্ছে জি, গ্যাস্ট্রিন রিসেপ্টর, ওটা মাঝেরটা হচ্ছে এটিপি, ওটা হচ্ছে প্রোটন পাম্প, এন্ড দ্য রাইট সাইড ইজ H2, ঠিক আছে, ওটাও রিসেপ্টর। একদম পরে দেখলাম হচ্ছে ভেগাস, যেখান থেকে বেরোচ্ছে হচ্ছে অ্যাসিটাইলকোলিন, and that is acting on the parietal cell, which is actually increasing the whole process of secretion of HCl. That's the basic idea of whatever is happening everywhere. Okay. Gastrin comes from G cell. Gastrin comes from gastrin এর উপরেও লেখা যেতে পারে, গ্যাস্ট্রিনের উপরে লেখা যেতে পারে it is G cell. So basically my idea is to give you a complete overview of whatever is happening, all the features, all the pathways, those are running in the parietal cell, and how things are helping things out. So basically vagus, it is under the neural control. Now neural control means it can be stress, it can be emotion, and that can act on the vagal stimulation. এই জন্য মাথায় রাখবে this gastric secretion and a lot of stomach disorders, these are connected to some concept called brain gut axis. Brain gut axis, এটার একটা separate PY segment আছে, maybe 5 weeks later we will be discussing in detail of brain gut axis. But the major thing is our digestion is very much under the control of our emotion. So তুমি একটা জিনিস লক্ষ্য করবে, if you are stressed you don't feel the appetite, if you are not stressed তাহলে বেশি, if you are seeing the ice cream it is a vicious cycle, 1 leads to 2 leads to 3 kind of that. So many conditions, under many conditions hunger may be superseded by your emotional state. Got it? Got it? There are certain conditions. Suppose, have you heard of something called depression? প্রত্যেকেই জানো। So এমন হয় ডিপ্রেশনের ক্ষেত্রে there are basically two varieties, one is the typical, the other is the atypical. Usually typical depression যেগুলো হয়, classical depression যেগুলো হয়, এদের ক্ষেত্রে দেখা যায় যে their appetite is falling down, they don't like to eat. Again, there are certain atypical variety of depression where people overeat to compensate the emotional response. এটা অনেকের ক্ষেত্রে হয় যে খুব মনটা খারাপ আছে বলে আমি টিভি দেখছি এবং খেয়ে যাচ্ছি continuously. So basically through that they are getting the extra dopamine to feel good. কিন্তু এটা প্রবলেম হচ্ছে they feel good FILL to feel good FWE. They keeping on feeling themselves basically. Actually that is leading to full. They will become a full after sometimes. So understood? This way you can remember basically. So emotional state সেটা ভীষণভাবে ইম্পর্টেন্ট এই জায়গাটা। সেকেন্ড যেটা sleep deprivation, it can have its effect on your appetite. Sleep deprivation, again that comes to the emotional state. Better sleep leads to better appetite. Less sleep may be disturbed appetite. Understood everybody? Next, so how we can cater to this things, কিভাবে এগুলোকে আমরা চেঞ্জ করতে পারবো? There are certain medication which are gastrin inhibitors. Gastrin inhibitors. Gastrin কি করছে? Gastrin actually is coming from the G cell and acting on the G receptor. Gastrin receptor that increases the HCl secretion. Medicine that inhibits gastrin, একটা মেডিসিন আছে যার নাম হচ্ছে প্রোগ্লুমাইড। এগুলো এমসিকিউ যদি এক্ষুনি হয়তো দেবে না, কিন্তু পরবর্তীকালে প্রি-পিজি এই এমসিকিউ গুলো আসতে পারে। সো প্রোগ্লুমাইড that blocks this and reduces the gastrin function, leading to reduction in HCl production. Vagus nerve, ACH. So if there is something which blocks this pathway, that can lead to reduction of ACH production. So anti-parasympathetic or parasympatholytic substances can reduce HCl production. Remember, parasympathetic increases HCl production, acidic production, increases the GI motility, movement in GI. So parasympathetic is switching on for the GI system. যদি কিছু থাকে যেটা anti-parasympathetic, a sympathetic system suppose, or whichever is degrading the ACH, if there is some kind of substances, then definitely it will reduce the HCl secretion. Then comes proton pump inhibitors, definitely. Proton pump inhibitors. We call it proton pump inhibitors. কে কে আছে? দু একটা নাম জানতে হবে, ওমিপ্রাজোল, প্যান্টোপ্রাজোল, বাস এনাফ। So basically, even if তোমাদের হয়তো টেস্ট করবার জন্য একটা নতুন নাম দিয়ে দিল, lansoprazole, rabiprazole, you are not expected to remember the medicine name at this point. But এই যে prazole শব্দটা শেষে আছে, that suffix will indicate that this is a proton pump inhibitor. Clear? Question আসতে পারে, this is an explain why question. The question which has appeared many times, proton pump inhibitors are used in acid peptic disorder. You can see. Clear? Similarly, we can have certain other medication that I can tell you. These are enterochromaffin-like cells which secretes histamine. Histamine acts on H2 receptor on the parietal cell, and H2 receptor activation leads to increase in HCl production. First of all, you need to understand that HCl, enterochromaffin-like cells, they secrete histamine. This is an amine. Chemically, it acts on the H2 receptor of parietal cell, leading to an H2 receptor. If it is activated, it leads to more and more HCl secretion. So, if we have anything that blocks this, then again we will have reduced HCl secretion. Ke block kore? There are H2 antagonists. Agonist মানে যেটা কাজ করাচ্ছে, antagonist মানে যেটা কাজকে অপোজ করছে. Everybody understood? Agonist means which helps to do this function. Antagonist which opposes this function. That means agonist is excited, antagonist is inhibited. Clear? So H2 antagonist, definitely it will block this H2 receptor. কাজ কি করবে? HCl production কে কমাবে. Definitely, if it is antagonist, there আছে নাম কি? ranitidine. তোমরা অনেকে নাম শুনেছো, অ্যাসিলপ, জানো তো? দিস ইজ দ্যাট অ্যাসিলপ, প্রত্যেকই জানেন দিস ইজ দিস। ওকে, সো H2 ব্লকার এইভাবে জিনিসটা কাজ করছে আর HCl কে রিডিউস করছে। সো দিস আর সার্টেন পাথওয়েজ, আগের দিনের সাথে আজকের যে ইন্টিগ্রেশন, অল দি পাথওয়েজ উই হ্যাভ জাস্ট ডিসকাসড ওভার হিয়ার। এখানে দুটো জিনিস আসবে, আমি এখনই মুছে দেবো। নেক্সট দুটো টপিক which are very important. One is why stomach itself not degraded by its own juice? That is question number 1. And the second is what is acid peptic disorder and how we can cater to it. Acid peptic disorder কি করে ঠিক করব, more or less idea এটাতেই পেয়ে গেছো, বাট জিনিসটা কি, this two will be our next two topics. এটা হয়ে গেছে, এটা মুছে দিচ্ছি। Everybody, we are giving you another 1 minute and then we will start. Activate enzyme pepsin. Acid medium, it provides, you already know in which pepsin acts optimally. HCl breaks down connective tissue and muscle fibers, including, this happens in the meat, whichever we are taking. So meat, larger molecules are broken down, connection between meat structure broken down. It denatures protein, definitely, and it kills microorganism ingested with food. That's why it is very important. People who are rampantly taking antacids for years after years, they are reducing their HCl. Actually, they are making themselves prone to infection. That's a very bad practice. But if you don't write these things, people will find you not a good doctor, basically. এখানে প্রত্যেকেরই gas. Here, basically, gas is something. 3 things actually kills human beings most: cancer, heart attack, gas. If you go to anybody, they will say that. But that's a different thing. Most of the times, these are connected with brain-gut axis, and these are kind of functional disorder. We will discuss about the functional disorder of digestion in a subsequent class, maybe in the month of March. It is there inside your syllabus. Anyway, so this is the action of the gastric juice. Occasionally, you can find this question as a 2-mark or 3-mark question in a big under a heading of a big question, basically. Okay, so now we are moving to. So first, কি কোনো কোশ্চেন আছে? বলো। Many places. Very good question. Very good question. Please sit down. Yes. So basically, proton pump inhibitors. Very good question. there are a few in kidney, and similar ATPases are present which are everywhere. Sodium potassium ATPase naam শুনেছো? It is in every cell. But however, this medication is mostly specific to the stomach, gastric proton pump inhibitor. That's a very good question. We really appreciate it. বাকিরা বুঝতে পেরেছো কোশ্চেনটার অর্থ? So it gives us an idea which she by thought she has reached to an idea. Every medicine can have some adverse effect. We need to make some specific molecular target for each and individual diseases. Got everybody? So usually this H plus K plus ATPase, this one is stomach specific. There are other proton pump inhibitors. There are not exactly H plus K plus ATPase, but many numbers, n numbers of Na plus K plus ATPases in body. Kidney te kichu H plus ATPase ache, kichu H plus K plus ATPase and K plus ATPase. These are also present in kidney. Usually these are gastric specific. However, it can stop it somewhere else, but that may not lead to that much of clinical symptom. ওই জন্য তো adverse effect কিছু থাকে, but not significant clinical symptom in other areas. Maximum number of H plus, this specific H plus K plus ATPase are found in the parietal cell. So more or less we get this. That's why that is another reason why we are against indiscriminate use of the medication. Lifelong এটা ইউজ করে গেলে there are multiple things which can happen. একটা major জিনিস এটা, if suppose acidic medium is not present in your stomach, you are keeping it down, definitely you are keeping your intrinsic factor down. Your Kessel's intrinsic factor will not be activated. So that may lead to faulty absorption of vitamin B12 at terminal ileum. Definitely you might have anemia, which is a pernicious anemia. Understood? So rampant use of PPI can lead to, or antacid medication can lead to that problem also. It can also lead to malabsorption because a number of micronutrients and other nutrients requires acid for absorption. তুমি যদি H2 aciloc, there are people who are eating aciloc just as a staple diet. 40 বছর ধরে aciloc খেয়ে যাচ্ছে. Definitely they are having other issues. Calcium metabolism that will be damaged. Iron metabolism that will be damaged because acid is very much important. Absorption এর জন্য, intrinsic factor এর জন্য, food degradation এর জন্য and immunity এর জন্য. And all of these might be affected if you take it rampantly. Understood? This is very important. Become a rational prescriber after 5 or 6 years. Rationality is very important. Why you are giving this? Rampantly giving these things are not good. And in better, first world countries, PPI just দোকানে গিয়ে দাদা একটা প্যান 40 দিন তো পাওয়া যায় না. You need prescription. Aciloc suppose in USA, Aciloc is an over-the-counter drug. Aciloc means H2 blocker, but not pantoprazole. Pantoprazole is not a over-the-counter drug. It is a prescription medicine over there. তুমি গিয়ে জাস্ট চারটে কিনে নিয়ে চলে এলাম, এটা হয় না। আমাদের তো অন্য ব্যাপার, আমাদের তো সিচুয়েশন ইজ কমপ্লিটলি ডিফারেন্ট। এনিওয়ে, okay. Coming to the next one, why stomach is not autodigested? This is very important. So এটাও একটা ইম্পর্টেন্ট প্রশ্ন। স্টমাকে তো নিজের এতটা অ্যাসিড আছে, সেখানেও ডাইজেস্টেড হচ্ছে না। So what do you feel? Why it is not autodigested? Mucus and bicarbonate and mucin, ওই mucinটাই মিউকাস করছে। So here we come to this concept of gastric mucosal barrier, and this gastric mucosal barrier is again very important for your exam. It is also a short note. Try to understand. This one are the cells, epithelial cells. Here, what we call it is tight junction. First point you need to mention is presence of tight junction between gastric epithelial cell. Tight junctions. What is tight junction? তোমাদের জেনারেল ফিজিওলজি হয়েছে? Yes, তাহলে tight junction বলো। What is tight junction? Acha. So basically tight junction is a very close connection between adjacent or neighbor cells. So components through those cells can't come out. Simply ব্যাপারটা এরকম, এইটা হচ্ছে tight junction, the point is there. So যা হচ্ছে, suppose if we have some acid over here, yellow color যেটা রয়েছে দুটো সেলের মধ্যে, it is not going over here through this there is no leakage of acid. যা কিছু যাবে তাকে through দিয়ে বেরোতে হবে, not through in between. No paracellular transport of acid. বুঝছো? Yeah, no paracellular transport. That's a tight junction. First one. Second point, যেটা হচ্ছে presence of mucus. Mucus, what it is doing? Mucus is providing a coating on the gastric mucosa. So luminal acid doesn't directly come in contact with epithelial cell. আবার বোঝার চেষ্টা করো, the whole process is like this. These cells যেগুলো আছে, inside cell, simultaneously H plus and C chloride minus are not being produced. তাহলে কি হতো, within cell itself H plus and Cl will react and make the HCl and cellটা নষ্ট হয়ে যেত. That is not being produced. Both have separate vehicles. H plus by separate vehicles, they are released over in this zone. Chloride is separate vehicle, through a separate vehicle released in this zone. Whatever reaction between H plus and Cl is happening over there in the lumen. In between this layer, the bluish layer is all the time intact, at least in healthy persons. Clear everybody? Otherwise HCl তো তুমি বলতেই পারো ওইখানে H plus তৈরি হলো and we have HCl minus. তাহলে সেলের মধ্যে হয়ে যাবে? No, because these cells they also maintain a physiological pH. কত? 7.4. Only then cellular things will work on. Only then enzymes will work on. So epithelial cell have a pH of 7.4, but the further you go, the pH falls down. And this happens first of all through the tight junction, because some amount of H plus and Cl may be present over here in between, and through this cell, if it passes into this area, it will degrade the HCO3. That never happens, because in between cell, এই যে লাইনটা যাচ্ছে দুটো সেলের মাঝখানে, এই ট্রান্সপোর্টটাকে বলে প্যারাসেলুলার ট্রান্সপোর্ট, আর এই ট্রান্সপোর্টটা থ্রু এন্ড থ্রু সেল যেটা যায়, this is known as transcellular transport. Paracellular transport doesn't happen because tight junctions are present. Tight junctions are specific structure by which one cell is connected very strongly and without any pore to the next cell. Clear everybody? Okay. Second was this. Third is the bicarbonate that is being produced, and this bicarbonate is actually helping to produce the mucin, and this mucin is producing this mucus layer. This mucus layer is thicker, closer to the epithelial cell, and thinner the more the further it goes away from the epithelial cell. However, up to lumen it maintains the proper pH. এই জায়গাতে মোটামুটি 8 এর কাছাকাছি থাকে, and এই জায়গাতে 2 এর কাছাকাছি চলে আসে. So pH due to the mucus here it is 8 alkaline, and here it is 2. After that it is below 2, there is the acid. So these are the three reasons যে কারণে our stomach is not auto digested by your skin. When it can get auto digested? Definitely if there is a breach in the mucus. মাথায় রাখবে, prostaglandins they help in maintaining the mucus layer. Prostaglandins is an important thing. So any medication that blocks prostaglandin can lead to a breach in mucus layer. Prostaglandin, you know, prostaglandin eicosanoids থেকে তৈরি হয়, cyclooxygenase pathway পড়বে মাথায়, এগুলো জাস্ট ইন ইওর প্যাসিভ মেমরি কিপ, বায়োকেমিস্ট্রিতে কিছুদিনের মধ্যেই আসবে. So basically which medication, এটা একটা কোশ্চেন, again applied physiology question, which medication is harmful for stomach? Painkiller medication, analgesic medication. Why? Because these medications block prostaglandin. So I am writing this one. This is again a question. We call it NSAID. Full form দেখা যাচ্ছে? হ্যাঁ? Non-steroidal anti-inflammatory drugs. তোমরা নাম শুনেছো? জেরোডল পি, অনেকেই নাম শুনেছো। পিটা তো প্যারাসিটামল, দ্যাটস আ সেপারেট পাথওয়ে। জেরোডল যেটা সেটা হচ্ছে অ্যাসিক্লোফেনাক। অ্যাসিক্লোফেনাক রয়েছে। অ্যাসিক্লোফেনাক ইজ আ নন-স্টেরয়েডাল অ্যান্টি-ইনফ্ল্যামেটরি ড্রাগ। এই জন্য মোস্টলি whenever we are prescribing analgesic we also give a proton-pump inhibitor. লক্ষ্য করে দেখবে এটা গ্যাসের ওষুধ দেওয়া হয়। That is true, that is rational. সেটা দিলে বেটার, কারণ কি এইটা গেলেই কি করছে, এগিয়ে প্রোস্টাগ্ল্যান্ডিনটাকে শাট ডাউন করছে। প্রোস্টাগ্ল্যান্ডিন is needed for mucus secretion, but otherwise prostaglandin is heavily invested in the pain and inflammatory pathways. তাই কোনো জায়গায় যদি ব্যথা হয় বা জায়গাটা ফুলে যায় after injury, if you give this kind of medication, NSAIDs, that gets reduced. that কিছু ব্যথা কমিয়ে দেয় basically. But the side effect of it also decreases or creates a breach in the mucous membrane that might lead to generation of an ulcer over there. সেই কারণে if you indiscriminately use this kind of medication, there are many people, mostly in rural areas, they are taking this medication, they are having pain for a number of reasons, and for a long time they are taking this medication. Indiscriminate use may lead to problem in the stomach, may lead to problem in your kidney, in liver, and multiple other areas, basically even in heart. So indiscriminate, irrational use is always to be curtailed. That's very important point from here basically. Anyway, so non-steroidal anti-inflammatory drugs, if you take it for a long time, it can lead to breach in the gastric mucosal barrier, may lead to acid peptic disorder. Clear everybody? That is one. Second question, that was done. Second question, just okay. Second is acid peptic disorder. It's again a long question. Acid peptic disorder, or we also call it peptic ulcer disease. Acid peptic disorder, or peptic ulcer disease. You can expect many questions from here again. This peptic ulcer disease, it can be of two types. One can be a gastric ulcer, the other can be a duodenal ulcer. So one can be a gastric ulcer, the other can be a duodenal ulcer. Gastric ulcer means the ulcer or breach in mucosa. What is ulcer, by the way? It's a breach in the continuity of the mucosa or skin. So any surface of our body, be it external surface, be it internal surface, maybe a luminal surface. Usually in health it should be continuous. There should not be any breach, any cut in the surface. If there is any breach in the surface, that may lead to the ulcer. এইখানেই ব্যাপার আছে, ধরো তোমার যদি এই জায়গাতে কোনো ব্রিচ হয়, suppose if there is a breach, there is a continuity, you can see there is a continuity of the mucosal barrier. Suppose there is a breach, what will happen? The luminal content will come in contact with the epithelial cell, definitely, and all things will start happening. Usually, ekdom jodi prothom diner picture ta, if you remember the cross section of GIT, which is so very important, if you look at that picture, first structure from the lumen side was mucosa, and then it was submucosal. So at that zone we have the muscularis mucosae. If you remember, mucosal moddhe muscularis mucosae. If that is broken down, only then the submucosa will be breached. And blood vessels, lymph gland, nerve fibers all run through submucosa. So unless and until it reaches the submucosa, blood vessels will not be affected. The breach up to the submucosa is required for this. Submucosa অবধি মানে প্রথমে মিউকোসাল ব্যারিয়ার ভেঙে গেল, তারপরে আপ টু সাবমিউকোসা ইউ হ্যাভ টু রিচ, তবেই ব্রিজটা সাফিশিয়েন্টলি ব্রিজটা হবে। সো when this happens, we call it peptic ulcer disorder. Peptic ulcer disorder, on the basis of its site or location, can be of two types. Either it is happening in the stomach, we then call it gastric ulcer, or it is happening in duodenum, we then call it duodenal ulcer. Now what will be the features, what will be the complaint of the patient? কেউ যদি বলতে পারো, patient কি বলবে? Stomach pain. Very good. So stomach pain মানে এরকম জায়গাতে pain. That is the, we call it, this area we call it epigastrium. তো epigastric pain কখন পেন হবে? গ্যাস্ট্রিক আলসারে, আর কখন পেন হবে তোমার duodenal ulcer?
খাওয়ার সময়।
So duodenal ulcer এ কখন পেন হচ্ছে? খাওয়ার পর। আর যদি পেটটা খালি থাকে তখন পেন হচ্ছে। সো রিজনটা খুব সিম্পল, যখন তোমার পেটটা একদম খালি, when you have nothing, so ample amount of acid is present, and this acid is coming in contact with the ulcerated part, pain is there. Nerve-টা যে stimulate হচ্ছে, nerve fiber গুলো in the submucosa, pain you are feeling. Duodenum, you need to put the substance, food, digested or partially digested food, to reach the duodenum. Once it is reached over there, acidic content is coming with the help with the duodenal part. So definitely after food. Clear everybody? After food will be having this problem. What else the patient may complain of? There may be some nausea, there may be some vomiting, there even in severe cases there might be blood coming out. Clear? Another situation might happen, both stomach and duodenum, these are the part of upper GI tract. Clear everybody? So if blood is formed over here, or if blood is leaking, what will happen? Stooler কোন রকম চেঞ্জ আসতে পারে? ব্লাড আসবে স্টুলে, তাই তো? ব্ল্যাক আসবে, আচ্ছা সেটা কি? So upper GI tract, if there is a bleeding in upper GI tract, that blood either it will be vomited or it will be passed through the stool. That's the thing. ওটা তো আর ওখানে থাকবে না, it will pass through the stool. তো স্টুলের কালার কি হবে? In that case, if there is sufficient bleeding in stomach, stool color will be red or black. Black. কেন black হচ্ছে? You are correct, যে blood আসছে, কিন্তু ব্লাডের কালারটা black হচ্ছে কেন? Not clot only, it will be degenerated and it will form hemosiderin, which is black in color. So basically we call it melena. এই জিনিসটাকে বলা হয় melena. Okay, so melena কি? Watery blackish stool that usually happens if there is an upper GI pathology, upper GI bleeding. We call it melena. Okay, এইটুকুই তোমাদের জন্য sufficient. এরপরে এগুলো নিয়ে we will be discussing. So these are the ways. তো clinical features যেগুলো হচ্ছে epigastric pain, nausea, vomiting, there might be blood in stool, there might be vomiting containing blood. That's the whole epigastric, that's the whole clinical features. Treatment are we have to reduce the overall acid content. কিভাবে করতে পারি? We can use H2 blocker, we can use proton pump inhibitor, we can also use some parasympathetic medication which will reduce the ACH. পরে আমরা এটা ফার্মাতে গিয়ে তোমরা পাবে. We can use some medication which protects or which creates a layer. এরকম একটা মেডিসিনের নাম হচ্ছে sucralfate. There is one medication, we call it sucralfate, 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 that will create a layer above the gastric epithelium. Clear? এই ধরনের কয়েকটা. What else? Certain lifestyle medication or certain lifestyle modification is required. পেশেন্টকে বলে দেওয়া যে স্পাইসি খাবার খাবে না, স্মোকিং need to be reduced, alcohol need to be reduced, proper spacing of meals is required, and you should not keep your stomach empty for an extended period of time. These are the things we need to remember. Clear everybody? কয়েকটা ছোট ছোট নোট জাস্ট লিখে নাও, এগুলো পরীক্ষার জন্য আসবে. Quickly we will be moving. So first is factors increasing HCl secretion. Factors increasing HCl secretion. Factors increasing HCl secretion. এগুলো জাস্ট লিখে রাখবে because MCQs will be formed from here. কি ফ্যাক্টর, কি জিনিস করতে যাচ্ছি? দুটো ছোট প্যারাগ্রাফ right now we will be writing. Two short paragraphs. One is about the factors which will increase the HCl secretion. Another is which decreases the HCl secretion. So quickly, increases HCl secretion. What are the factors? Vagal stimulation. Quickly write. Yeah, just write vagus. Then ACH. Then ACH, acetylcholine. Acetylcholine, yes, ACH. Then third factor is histamine. HIS, just remember, histamine. Fourth factor is gastrin. Fifth is insulin. Sixth is protein and protein digested products. Factors decreasing HCl secretion. তোমরা একদম শর্ট ফর্মে লেখাটা প্র্যাকটিস করো, আদারওয়াইজ ইউ ক্যান্ট কমপ্লিট আ নোট। প্রোটিন কে P small r এভাবে কুইকলি লেখাটা প্র্যাকটিস করো। Factors reducing HCl secretion. First, somatostatin. Prostaglandin E2, PGE2. Capse, PGE2. Somatostatin. Next is prostaglandin E2. All the prostaglandin you write like this, PG. That is sufficient. PGE2. Third is TGF alpha. TGF alpha. This is a growth factor, tissue growth factor, alpha variant, TGF alpha. TGF. ওটা লিখে দিয়েছি, উপরে লিখে দিয়েছি, TGF alpha. Increase acidity itself decreases HCl secretion. So acid যদি বেড়ে যায়, increase acidity itself decrease the HCl secretion. Then CCK, cholecystokinin. CCK, cholecystokinin. Then VIP, vasoactive inhibitory peptide, VIP. Then GIP, gastric inhibitory peptide, GIP. হ্যাঁ, vasoactive এখন তোমরা জাস্ট এটা লিখে যাও, আমরা পরে হরমোনের উপরে জিআই হরমোন সেপারেট ক্লাস হবে, এখন সময় নষ্ট করো না। যারা করতে পেরেছো ভালো, যারা পারোনি কন্টিনিউ। ভিআইপি vasoactive inhibitory peptide, সিসিকে cholecystokinin, পুরো নাম লেখার দরকার নেই, জাস্ট রিমেম্বার দিস। এন্ড এই মেডিসিন গুলো, জিআইপি গ্যাস্ট্রিক ইনহিবিটরি পেপটাইড, জিআইপি জাস্ট লিখে ছেড়ে দাও। পিপিআই প্রোটন পাম্প ইনহিবিটর, এবার মেডিসিন H2 ব্লকার, পিপিআই H2 ব্লকার। আমি খুব বেশি সময় এটা নিয়ে নষ্ট করিনি, করতেও চাইছি না, বিকজ এভরি বুক হ্যাজ দিস। এটা একটু হয়তো ইউ মাইট ফাইন্ড আ লিটল ক্লামজি, কোনো অসুবিধা কিছু নেই। এভরি বুক হ্যাজ দিস, অল দ্য সিক্রিশন যখনই লিখবে ফার্স্ট মেক ইট ওয়াটার অ্যান্ড সলিডস, and then under solids make it organic and inorganic. If you can just remember this, that is sufficient to score pass marks. Inorganic এর মধ্যে you will just give certain cations and anions. কি কি cations থাকবে? Gastric juice বলে H+ টা থাকবেই, রাখতেই হবে। Otherwise you will also have sodium, you will also have potassium, you will have magnesium. Negative এর মধ্যে to some extent bicarb রাখতে পারো, but chloride must. Gastric এ যদি chloride না রাখো তাহলে চলবে না, to some extent sulfate ও থাকবে। এই জাস্ট কেউ এটা নিয়ে অতটা মাথা ঘামানোর দরকার নেই। এনজাইম ইউ নিড টু রাইট, পেপসিন এটসেট্রা, গ্যাস্ট্রিক লাইপেজ, এনজাইম গুলো লিখতে হবে। এটা নিয়ে আমি ওই জন্য বেশি মাথা ঘামাচ্ছি না। এনি টেক্সট বুক দ্যাট ইউ আর ফলোইং, সাফিশিয়েন্ট ম্যাটেরিয়াল ইজ প্রেজেন্ট। আচ্ছা, আমরা 3 থেকে 4 মিনিট সময় নেব টু ফিনিশ আপ দিস থিং। Phases of gastric secretion. This one you can take a snapshot. Basically there are 3 phases. আরো ফেজ হয়, but 4 phases we can go for. One is the cephalic phase. Cephalic phase মানে মাথা, খাবারটা মুখে যায়নি, মাথার সামনে আছে। মাথার সামনে আছে মানে you are seeing or smelling the food. That is the cephalic phase. So cephalic phase এর দুটো জিনিস হতে পারে, last day also we have discussed. One is the conditioned, another is the unconditioned. Conditioned reflex মানে সেখানে তোমার সমস্ত hypothalamus, your vision, your brain, other parts are active. Limbic system, emotion, everything is taking part in the conditioned reflex. Unconditioned reflex, that is the taste. Particularly your taste sensation গুলো on হয়, only then you will be having the unconditioned reflex. কি করে জিনিসটা হচ্ছে? Both reflexes ultimately switching on the nucleus tractus solitarius, which is a vagal nucleus in our brain. Taste sensation or non-taste conditioned reflex, সেক্ষেত্রে limbic system, hypothalamus and other sensory systems, visual systems, spatial senses, they are taking a part over there. They will switch on the nucleus tractus solitarius. Vagal stimulation leading to increased acetylcholine secretion. তারপরে কি হয় তো দেখে নিয়েছো, ওই যে পিকচারটা ছিল, that will lead to switching on of G2 receptor, H2 receptor, সবটাই একটু আগে দেখিয়েছি, NH+, K+, ATPase, and the whole process will be switched on by the vagus. That's the point. Jodi phases of gastric secretion, which is a 2-mark or 3-mark question usually, that is the cephalic phase. You can see this is by the psychic stimuli, by the smell, by the thought. It is coming in. And it is also vagally mediated, and anything vagally mediated means nucleus tractus solitarius is playing a role over here. Just jodi basic ta thik thake, you can explain these questions usually. And 30 to 50% of total gastric juice secretion is under cephalic phase. That means you even do not require any food inside your mouth for 30 to 50% of gastric secretion. Understood? Because that is just by sight, thought or smell of a food you can have this. Secondly, we have gastric phase, where presence of food in the stomach is the factor that leads to local response, local reflex and response to gastrin. Very important. What is local reflex? Local reflex is mediated by enteric nervous system, Misna plexus or back plexus. This myoenteric plexus, whichever she is talking, that is also correct. So that leads to 50 to 60% of total. So that is the majority over here. Definitely it should be. You need food for this. That's the majority over here. And the third is intestinal phase. That is when the food bolus passes the stomach. That means gastric emptying has occurred and it has moved into the duodenum. And here basically reflex and hormonal feedbacks act. এখানে main hormone যেগুলো কাজ করে, one is GIP, other is BIP, the third is CCK, which just now we have discussed. কারণ কি, once it is passing the stomach and in the duodenum, we need some check mechanism which will reduce the flow of HCl. Right now stomach is empty, gastric emptying has opened. So এখানে যদি HCl continuously keep on secreting, that will lead to disease. Basically, HCl secretion two রকম বলেছিলাম, one is the basal secretion, whole day secretion, the other is the bolus or pulse secretion. When food is there, only then secretion is going up. So this bolus part is gone. Basal part, which is vagally mediated, that will continue. You have food, you don't have food, you have sight or thought of food, you don't have sight or thought of food. Mostly if the class is going good, you don't even think of food. But even at that time, basal secretion will be there. Clear? এই জায়গাটা মোটামুটি গেল। And see, the last part is the very best secretion, because that is actually negative to the whole thing. Now, coming to the last minute of the class, certain things, certain experiments have taken place over last 2 centuries to understand the gastric secretion. তার মধ্যে কিছু animal experiment আছে, Pavlov's is one. The other experiment is known as sham feeding experiment. Sham feeding experiment. Sham means false feeding experiment. কি করা হয়েছিল? Just you need to remember this. কিছুই না, an experimental animal, and mostly dogs are very poor and unfortunate in most of these cases. We get them somehow, and we are traitors basically. As human we are traitors. We get them, pet them, and then use them for our science, so-called science. So what we did, we poor dog, for no reason almost, we just cut its esophagus. So once the esophagus is cut, and the part of the esophagus there is a stoma. Stoma means abnormal opening. So esophagus টা তলা থেকে কেটে, esophagus is not now going to the stomach, rather they have made an abnormal opening of esophagus in the anterior chest wall or anterior abdominal wall. So what's the benefit of this experiment? Benefit কি, যে esophagus এর মধ্যে দিয়ে খাবার যাবে, but this will not reach the stomach. It will come out. Clear? Everybody making sense? It may not make sense, however, from humanity point of view, but that's the science over here. So কি দেখছে, there are main thing, stomach is now open through that thing, or আমি আরেকটা ছিদ্র করে স্টমাকটাকে ওপেন করতে পারি, and now I have put an cannula inside this stomach. So the whole animal model is, animal is eating the food, the food is not going to the stomach itself because stomach connection, esophagus stomach connection is cut and esophagus is open. So food is going from here and food is coming out from anterior abdominal wall. Simultaneously we are putting our cannula inside the stomach so that we can measure the acid output in the stomach. এখান থেকে কি পাওয়া যেতে পারে? We can get the BAO, basal acid output. We can also get the PAO, that is the peak acid output. কি করে করছে? সারা দিন তো এই ক্যানুলাটা রাখা আছে inside the stomach, through it is collecting the whole day acid, and we are getting an idea of the basal acid output. Plus we are also giving food inside the mouth of the animal and the food not going over there. That's why it is sham feeding or false feeding, but it is seen whenever the animal is taking food, acid secretion is increasing. So that's the sham feeding, and that gives us an idea of the cephalic and esophageal phase, which is previous to gastric phase basically of the overall acid secretion. Clear? That is a sham feeding experiment. Huh? They can give it IV fluids. IV fluids. বেঁচে আছে মানে তো it is not এখন তো আর বেঁচে নেই এখন তার সায়েন্টিস্টও বেঁচে নেই যে করেছে হ্যাঁ তখন মানে they will make it alive by IV fluid. Clear? ওই টাইমে IV fluid দিচ্ছে ওইভাবে ওটাকে রাখছে, or you can also feed it through the stomach যাতে গ্যাস স্টমাকে যায়। মুখ দিয়ে খেলে আসবে না, কিন্তু there's a stomach. Through the stomach means an orifice which is making a connection over there. GI তে গ্যাস স্টমাকের মধ্যে ডাইরেক্ট you can put partially digested food. These are the ways. এইভাবে হয়েছে। Similarly, human experiment has taken place. তাহলে কি human কে ওভাবে রাখা যেতে পারে? No, you can't. Because when it comes to human rights comes. When it comes to animal, nobody comes. Kind of in terms of science. Animal rights are also there anyway. So human এর ক্ষেত্রে কি করা হয়েছে? There was one particular patient who had a gunshot injury and had an opening on stomach. So opportunity was taken and this patient was was followed and all these experiments took place. Another person had an operation for cancer, and after that the scientist actually approached him and we got those things. I think I have the name. One is Saint Martin. Saint Martin had a gunshot wound and he was experimented later on. And another one is Tom Little. Tom Little, he had a stricture gastrostomy. Actually, what happened in Tom Little, if I remember, he took some very corrosive substance or very hot liquid. So his esophagus got stricture, ekdam puro pakad hoye gayo. So he had to undergo a procedure called gastrotomy. Mane esophagus diye ar kichu jabei na because of the accident. Now gastrotomy korate ki hocche, the part of the stomach is open, ekta valve system kore deoya jete pare, and through that he used to take food. Okay, তাহলে স্টমাক দিয়ে ফুডটা নিতে হচ্ছে, partially digested food he used to take for the rest of his life. So scientists did their experiment on this patient also. His name was Tom Little and he did a very big thing for the science. Clear? So here we end for today. Next day have a আমি শুনতে পাচ্ছি, জোরে বলো। What she saying? Esophagus is removed. We will. Yes, esophagus is removed.
We could put a tube connecting the stomach.
Yes, we can definitely do it. We can, and in many cancer surgery we do it. We can put any tube anywhere, and we can cut any organ. And another stoma can be formed. Clear? It is done. It is done. Esophagus. তোমার গ্যাস্ট্রো ডুওডেনোস্টমি করা হয়, ডুওডেনো জেজুনোস্টমি করা হয়, গ্যাস্ট্রো জেজুনোস্টমি করা হয়, many options are there. In surgery you will be learning about this. Here we can put that.
So let's quickly finish this, whatever we have to go through, and then we can free for everything, right? So I understand you have covered some of the contents on these particular developmental aspects about the skeletal system, right? So it's not about these particular formations of these skeletal element, which is a kind of like embryological process. So I want to just like continue this particular aspect on these embryological skeletal system, and we'll be focusing on three aspects of these content. We are going to talk about this particular three areas primarily about this today's lecture. We're going to talk about the vertebra, and in between the vertebra we have a disc. We call them as intervertebral disc. So So we're going to learn about the formations of this vertebra and the intervertebral disc and how this particular component are there and what the clinical relevance on them. The second aspect of which we are going to talk about is, we call them as sacrococcygeal teratoma. And the third, rather most important, is neural tube defect. So basically, we will be focusing today on the clinical relevance or the clinical understanding on clinical aspects of this particular skeletal system error. Most commonly, we are going to deal with some diseases that we are going to see in our clinical life. So this is what we hardly going to take like 25 minutes. So hold on for 25 minutes to see what things comes over here. So we already have gone through this particular system about the formations of the skeletal system. Now the skeletal system, we have some of these areas which is developing from some part of these particular developing areas of this particular embryo. So that for this understanding, we have to go to understand how this particular skeletal system, particularly emphasizing on the vertebra, develops out here. So this is what we begin with. We have this particular disc. We call them as bilaminar germ disc. It has two layers. So we have this particular two layers existing, but unfortunately we are missing one layer here. So we have to incorporate another layer. We call them as trilaminar. So we have to make this trilaminar germ disc, which is present in this particular region. So out here, what we are seeing here, the cut sections of this particular zygote which is implanted in this, like the areas which is known as the endometrium of the uterus. Now you can see this particular tube, which is split open into two halves. You will see two bubbles there. One is on the top side, one is on the bottom side. So these are known as amniotic cavity, eopside cavity, and in between we have these two layer germ disc which is existing in it. So these particular areas, we have the two layers which have got two different colors, yellow and these orange and blue or red or something, right? A little color brown, or rather very color brown. You understand this? So we were with me with this particular color sense. Oh, we'll talk. So we have two colors here, right? You know the colors very well, better than me. So we have two colors over here. These are the two plates colors. So we are not satisfied having two plates here. We need another layer to incorporate over here. We need muscles. We cannot leave with this ectoderm and endoderm only. We need the muscles which is coming from the mesoderm. So here comes with this particular story, which is enlarged over here, cut over here, and you're seeing this area which is like the amniotic cavity site. So this amniotic cavity site soon appears with some kind of features. We call these as features of primitive spray, which consists of this particular node, which has a hole in it, and it has a groove. So this is how the story begins, and these particular cells, which is present on this region, through these particular plates, they move across. And they move across and move cranially, caudally, and laterally in between these two blue and this orange layer and settle down. And this is how they create from the two layers into three layers. So this in-between layer, which is made out here, we call them as mesoderm layer. We have this particular red layer in the middle, which is going to be the muscle or mesodermal tissue, and this yellow layer or orange layer, and as well as the blue layer. The blue layer is going to be this particular ectoderm, and the blue, which is going to be ectoderm, and eventually that gives rise to the formation of the neural tube event. That's like our brain is developed from this particular ectodermal tissue. Surprise, right? From the skin to brain. So, and the lower one, which you are seeing here on the bottom side, the yellow, which is going to be the gut tube or inside thing. Okay? These are the three things. Now, our prime focus for the day, we are not going to talk anything and everything. We are going to focus on this particular red light, which is known as the newcomer out here, which is known as the mesodermal tissue. Now, this particular mesodermal tissue, we are going to just like zoom the lifespan of this and understand how this particular mesodermal tissue evolves. Now, the next phase, this is around the age of like 3 weeks, right? So, 1 week ahead, 4 weeks, like it moves over here, we see this particular transformations of this particular red dye. And we'll be focusing on this class about this, whatever the fate on this particular red tissue, which is known as mesodermal tissue. Now you see this particular mesodermal tissue, it is around 3 weeks over here, and compared to this one, which is 4 weeks, which is on the B picture. Now you see this mesodermal tissue, which is present in the central part, which has got thickened, compared to the lateral side, which is thinned out. You see that on the lateral side, there are some kind of holes appearing in it. There are some holes appearing in it, right? So small, minute holes are there. So this particular there holes, which were initially, couple of them, and eventually, after time progresses, these small holes coalesce, mix with each other, makes a big hole. So we just see this particular transformation of this particular mesoderm, and based on the position of this mesoderm, we classify it. So this is the midline where you have this particular, the black tissue, we call them as notochord. And on the top of the notochord, you see that the ectodermal area showing some folds. That folds is going to be the neural tube, which is going to be our future brain. Now, if you say this particular mesoderm, which is around this particular midline, which is framing the axis, we call this mesoderm as paraxial mesoderm. And which is to the lateral side, we call them as lateral plate mesoderm. And on the lateral plate mesoderm, you see there are holes which are coming up, and eventually, as I'm saying, as the time progresses, this lateral plate mesoderm, all the holes coalesce and joins with each other and makes a single cilium, a single hole. We call them as intra-embryonic body cavity, which is making a hole over here, splitting this lateral plate mesoderm into two parts. One is going with this amniotic cavity, one is dropping down with this yolk sac. Right? And this thing evolves eventually. Now, out of these things, we are going to focus on this region of the mesoderm. We call them as paraxial mesoderm. So our point of concern, we are going to talk about the vertebra and related development to this particular vertebra. We are going to focus on this particular tissue, which is known as the paraxial mesoderm. Now this is a schematic picture. This is how this particular thing looks like if you are taken in a live embryo, cut through, and MRI scan is done and colors have been used. We have 3 different color codes used in here. You can identify the different color codes and different types of the mesoderm which you are looking here. Yellow, blue, and everything right there. Okay? So you can see this color. What color is this one? Yellow? What color is this one? Yellow. Alright, yellow. Alright. So what yellow signifies out here? What kind of mesodermal tissue? Paraxial mesoderm. How do you know this is paraxial? Notochord. What is this notochord? What is this green dye? What is this? Green one, green tissue? This is green, right? Yes. So what is this? Notochord. And what is on top of the notochord down here? Ectoderm. Neural tube. Basically, it's a future of ectoderm, right? So ectoderm transformed into tube, which is going here is neural tube, which is going to be our brain, right? So you have to be mindful with the brain. So neural tube with this one. What is the red one? Intermediate mesoderm. What is this like the 2 colors over here? Blue and some blue. These are what part of mesoderm it is? Lateral plate mesoderm. So lateral plate mesoderm has got 2 layers. So multi-layer, parietal layer, plantic, and chloride. All these layers are there, right? In between the cavity, what is that? Intra-embryonic cilium. That's going to be the body cavity. Now we know all these things over here. What this holes are for? 1 and 2. What this holes are for? This opening on the side. What this for? This opening? Tube, some kind of tube related to the vascular system. We have this aorta. So we have 2 aortas to start with. We have this abdominal aorta. Initially we had 2 aortas there. So we call this aorta as dorsal aortas. There are 2 dorsal aorta which are there. So we understand that what is the paraxial mesoderm is, right? We understand what is this intermediate mesoderm, and we understand what this particular lateral plate mesoderm and intra-embryonic cilium is. Now we see the transformation of this particular yellow guy, which is known as this paraxial mesoderm. It breaks down into smaller segments. We call this smaller segment as somite or somatomere. Right? We'll learn about that particular thing. So future fate of this particular yellow plate over here, it breaks down into smaller segments as the time moves on. Now there's a particular time of appearance of somites. It appears from the craniocaudally over from this cranial region going down, and it has appearing age which is 28th day to this particular 5th week. That means say 35 days. Within by that time, all the somites have appeared, and the total number which could be 44 to max. 42 to 44 max somites will be there. So this particular somites which is appearing in this particular site over here, which has a sequential pattern, and this particular pattern, by counting them, we can basically pinpoint the age of this embryo. So we call this as a somato clock. So as the clock is ticking, the somites are appearing. Counting them, we just like know the age of this. This is known as carbonic scaling. So we know this embryonic type. So if you end up in doing this ultrasound super specialization, you have to do this particular mapping in future by counting the somites and appropriately denoting the age of this particular embryo. But anyways, we have this particular somite blocks which are coming over here. So this is the story about this, how these particular things are evolving and how these things are coming. Now, this particular somites which you are seeing here, which is present in the paraxial region, and this particular paraxial region, we have this particular somites which can be divided after two parts, which can be divided into two halves or two sections. One is close to the midline, other is away from the midline. So if you just like to split this particular somites or this particular like a block over here and cross it, we have this midline or close to midline and away from the midline. That can be divided into two halves. So close to the midline, we call them as sclerotome. And away from the midline, we call them as dermatomyotome, or in short, dermatotome or myotome. So we have these two segmentations of the somite coming on. So, once again, we have started with this particular thing which is known as the mesoderm. So we call this particular mesoderm which is having three components. What these components are? What these components are? Axial, intermediate, and what do you think? So what are these particular mesoderms are? What are the components of it? Component part. So we have three components over there which is there. Now our point of concern is with the paraxial mesoderm, which breaks down into somites. And this particular somite has a particular pattern in appearance. And this particular somite in each segment can be divided into two halves. One is known as the medial half, other is known as lateral half. This is the entire thing which is together we call it a somite. So eventually we will see that this particular somite cells separates themselves into medial half and the lateral half. The medial half we call them as sclerotome tissues, and the lateral half we call them as dermatomyotomes. And dermatomyotomes eventually splits into two segments. We call them as myotome and dermatome. So they're going to give rise to the skin of the dermis layer of the skin, and myotome eventually going to give rise to the skeletal muscles. Now our focus will be here on this particular medial area which is known as the sclerotome. So sclerotome, how this particular evolves to transform into formation of the vertebra and the intervertebral disc. That's the point of concern for the day. Now, we're going to talk about this particular vertebra. Now, if you are looking at this particular picture, you will see in this particular vertebra have got three components. One is the central component of the vertebra. The central component of the vertebra, we call them as vertebral body. And then we have the processes. These processes on flagging into three different areas. One is on the posterior side, one is on the lateral sides, etc., etc. So this particular flagging or this particular outreach area, we call them as process. So this particular vertebra has got few parts. We call this particular body vertebral process, and as this process gets into, it holds a cavity in between, through which the spinal cord and the covering of the spinal cord drops down. We call this particular area as the foramen, intervertebral foramen. So these are the three components over here, which is coming over here. So eventually, we have to know where from this particular vertebral arches are coming, where from these bodies are coming, how these particular foramens are enclosed out here. So that's the point of concern. Now, if you know how these things are coming, what could go wrong if these particular components do not meet properly and can lead to some disease? That's the point of learning for the day. If you do not know the normal thing, you cannot like figure out how the abnormal thing is something else. So this is what we are coming to understand over here, the vertical body and this particular area, right? Now, let's understand how these particular components are coming. Again, whatever we started with the mesoderm. Intraabdominal mesoderm splits into three parts. We are holding this part, we call them as parietal mesoderm. Parietal splits into somite or somitomere. Somite splits into two components. We call this as the sclerotome and the dermatomyotome. Dermatomyotome, again two components, dermatome and the myotome. The sclerotome, which is the part close to the midline. So next picture clarifies this. This is the developing neural tube. This is the notochord. These are the signal points where it's kind of giving the signal or attraction to the parietal mesoderm tissues. This area we call them as sclerotome. This area we call them as dermatomyotome. The sclerotome cells move with the signals of this notochord close around this particular developing neural tube and circles around that particular region. And right side we have a parietal mesoderm. Left side also we have the parietal mesoderm. So from the both ends of these particular medial tissues of this particular axial tissues, they move around the midline and circle around this particular region, around this notochord, developing neural tube, and eventually from this and sequentially gets into this. So this particular scleral tissue initially buries this particular notochord, forms this part of the body or centrum part of the vertebrae. Now once the centrum part is formed, then this particular neural scleral tissue moves into different areas, transversely and tangentially and medially, and moves around and goes around this particular developing neural tube, and eventually they give rise to formation of this particular entire wholesome vertebrae. So this is how the vertebrae are formed. So from this particular scleral tissue, cells they moves around. They move ventromedially to form this particular vertebral body. They move laterally to form this transverse process. They move medially on the dorsal side or the posterior side to encircle around to form to these particular areas which is known as arch. And eventually meets there. So any of these things goes wrong, we get a faulty developed vertebra. And if you imagine that particular vertebra holds an important neural structure which is the spinal cord. So if you have a faulty vertebral encasing out here, we might end up in a defects in vertebral defects, which may land up into the neural defects. Right? So this is how these particular things can go wrong. So this is what we are going to learn about the neural tube defect and how this vertebral assembly can go wrong and eventually possibly give rise to the disease. So this is how. This much are we clear or not? Any doubts, any queries about this much so far or not? Good? How these vertebral bodies are formed, how these processes are coming into, and what part of this particular mesoderm contributing. That's it. Simple thing. We are not just asking you to just like narrate each and everything, but the gist of the thing, how these things are coming into here, how these things are transforming. So, from here we are going to talk about the vertebra, then we are going to move into understanding about this particular segment. Now this is an interesting part. Now we see the somites there, right? So it's a cubical block which is broke down around the splitting of these parietal mesoderm. So this is how this particular cubical blocks are there. So we have this particular 44 or 42 cubical blocks there, right side, left side, somites are there. Now we see that as the time progresses, this particular neural tube, which is completely formed and fused, eventually give rise to the formations of the sprouting of the nerves, which is known as the spinal nerves. So spinal nerves are coming out as a sprouting over here, and this particular, as the spinal nerve is coming, this particular spinal nerves are giving some signals to split this particular somites into segments. So as you can see, this particular thing is bubbling out. It's kind of like it's a point or incipient spinal nerve where this particular spinal is going to come. And you can see this particular picture with fluid. The spinal nerve is kind of like getting in and forming over here. Now as the spinal nerves are coming, this particular spinal nerve is splitting this particular each somites into cranial half and caudal half. And each of these somites over there. And eventually, as you can see, this each somites is divided into upper half and lower half, upper half and lower half, segmented. And as the time progressed, this lower half of the upper somite and upper half of the lower somite, they eventually unite and eventually unite to give rise to this particular eventual spermite blocks. So this is a little bit complex thing, and this particular complex things we may not have to just understand the whole detail because we are not just like emphasizing on. But I'm just like saying about this particular how this particular spinal nerves are coming, also splitting these somite blocks in a cranial half and a caudal half. But anyways, I'm skipping this particular areas which might be the little understanding defects which might land up into some other things. But anyways, we are coming into this particular region. So we have learned about the vertebral formation, vertebral body and web processes. Now we are ending up into a new domain which is the intervertebral disc. So we have the vertebra and the body of the vertebra, which is the central part. In between the body of the vertebra, we have a disc. Now we call this vertebral disc as an intervertebral disc. Now intervertebral disc and diseases arising of the intervertebral disc are more common or more frequent in our day-to-day clinical life. Now what is this intervertebral disc? It's an in-between disc present in between the vertebral bodies. Now how this particular intervertebral discs are composed of? Now this particular intervertebral disc has two components. One is the outer component. If you look side of kind of things, you see that we have two other colors. It has a central part and it has a marginal part or periphery. So this particular marginal part of this disc, which is zoomed out here, we call them as annulus fibrosus, which is annulin or kind of encircling. And it has a central part. We call this as a central part as nucleus pulposus. Am I clear? So it has two components. The central part, we call them as nucleus pulposus and annular fibrosus, which is fibrosis. Now these two elements, which is composing the entire whole of intervertebral disc, is sourced from two different areas. So that's why we have to know, we have to understand where from this nucleus pulposus developmentally coming, where from this annular fibrosus developmentally coming, and what go wrong with this particular intervertebral disc, right? So this is what we are going to learn out here. Now again we are moving back to these particular areas of this particular vertebral development. Now you see this particular picture. What is this purple guy? What is this blue guy? Green guy is right here. So this particular green one and what is this blue dot or kind of purple dot present in the center? Purple is the notochord or the remnants of the notochord, and the green one is paraxial mesoderm. And which part of the paraxial mesoderm? Medial part. What is the medial part is called? What's the medial part of the paraxial mesoderm? Sclerotome. So sclerotome is basically giving rise to this particular bony component, and this particular central one which is present in this particular body which you see in the purple is the notochord. Now, listen carefully what I am saying, alright? So this particular, in case of this vertebral formation, this particular purple tissue, whatever you are seeing in the body of the vertebra, the notochord tissue, in case of this vertebral formation or vertebral body formation, this purple tissue is completely absorbed or completely replaced by this sclerotome tissue. So when we are getting a full-term adult vertebra, we do not have any remnant whatsoever about this particular notochordal tissue. Am I clear? In case of this particular tissue, this is still evolving, right? See, this is not fully formed. So once this thing is fully formed, this notochord tissue will be completely replaced by this sclerotome tissue or sclerotome cells, which is paraxial mesoderm, which is the interembryonic mesoderm. Am I clear or not? Now, contrary to this one, which is the intersegmental area, which is lying between the somites. So this is the intersegmental area. You see that this particular spinal nerve is coming and eventually pushing and splitting this somites into two segments. Now this particular intersegmental area have moved into this. So this is intersegmental area through which the nerves are passing. So this particular intersegmental area is basically the land of this intervertebral disc or future land of the intervertebral disc. So this particular intersegmental area where this particular vertebral sclerotome is giving the passage to this particular nerve, we cannot leave this particular vertebral body hanging like this. We have to place something in between them. So that particular area where this particular intersegmental area is there forms this particular intervertebral disc. Now this particular intervertebral disc out here is composed of these two elements. Now, here comes with this nucleus pulpus. We have the notochord which is existing on that particular area. So that particular remnant of the notochord tissue in the intervertebral disc area gives rise to the nucleus pulposus and it remains at ATPase. In case of the vertical body, we say that notochord is replaced by the scleroderm tissue. In case of the intersegmental area where this particular future intervertebral disc is forming, this particular region, the notochord tissue, transforms into this kind of tissue. We call them as nucleus pulposus. If you see these nucleus pulposus in a living dissection or live surgery, it looks like a jello. You see the jello, right? The jello sweet kind of thing, the topping. It looks like a jello. So this particular notochord tissue remnant in our adult life remains as a nucleus pulposus, even when we are born, even when we are controlling, even right now with us. Now, other part, which is this annular fibrosis. This annular fibrosis is contributed by the same scleroderm. The scleroderm tissue that is coming from the parietal mesoderm, that particular parietal mesoderm giving rise to this particular annular fibrosis component, and this nucleus pulposus is nothing but composed of this particular remnant of the notochord. So this is the only region where we have this embryonic tissue existing as this particular component of this spinal cord, which is present in here. So we have these particular areas of the intervertebral disc, and intervertebral disc, IB disc, which is having two components, nucleus pulposus and annular fibrosis, and you have to know the source of it. So MP, nucleus pulposus, and nucleus pulposus is coming from the notochord, and annular fibrosis. Somebody is cursing amongst yourself, maybe. Want me to finish this thing quickly? I'm trying my best. Annular fibrosis, this is kind of like outer skeletal element which is coming from the scleroderm, which is coming from the parietal mesoderm, PAX, and which is intra-embryonic mesoderm. Eventually they are coming. So this is what we have to carry out here. The different sources or embryonic sources of these intervertebral disc. Are you clear or not? So this intervertebral disc is coming from these same sources. So this particular scleroderm tissues around this particular notochord encircling here and giving rise to the whole thing around, keeping this particular notochord tissue intact in this intersegmental region where it is forming this disc. In case of the vertebra, it is completely replaced by the scleroderm tissues. It is not having any kind of notochord tissue in the vertebra. Rather, in this particular nucleus pulposus, which is intervertebral disc region, we have this particular problem. So this is kind of legit notochord tissue can remain in our body without disturbing or without hampering any of these particular body system. Alright, so this much of notochord tissue remnant is permitted, which is encircled by this annular fibrosis. Now this particular disc, as I am saying, in clinical life, which you are going to learn now. Now this particular tissue, which is this nucleus pulposus of this annular fibrosis is made of. You can see this particular jello thing, if you're pushing it too hard, if you're compressing it too hard, it can break through this particular annular fibrosis and can move out or herniate out. We call this as the disc herniation. Disc herniation is nothing but the pulposus nucleus which is herniating out or popped out. And that's in a layman terms we call them as disc prolapse or prolapse disc. So where this particular vertebral disc is prolapsing out, and if it is prolapsing out or pushing out, it can compress the intersegmental nerves. What nerves? The spinal nerves. So those spinal nerves are going to form this particular your nerves, femoral nerve, sciatic nerve, all the nerves which you're going to see and dissect soon. So those nerve roots can be compressed and give rise to some diseases. So if the sciatic nerve roots are compressed by this prolapsed intervertebral disc nucleus pulposus, we call this as a disease as sciatica. Okay? So this is how this particular thing matters to us about this nucleus pulposus thing. So moving from here. So this is what we are talking about, this intervertebral disc which is coming into here and eventually giving rise to this particular notochord tissue, holding it and encircling it around this particular regions. Sclerotum part contributing to what? Notochord remaining over here. So this is all about this understanding. Now coming to the disease aspect, this is the last part. So as I am saying, the notochord which should be legibly present around this particular intervertebral disc. Now, if this notochord tissue or the cells, if present in any other parts of the body other than this particular region, most commonly present in the cranial part or the caudal part of the spinal cord. So, it can give or yield a kind of tumor. We call this as tumor as a chordoma. So, chordoma is a disease or a tumor which could be malignant, which could be benign, depending on the state of this particular tumor, and giving a disease. We call this as a chordoma. So chordoma is a remnant of the notochord can give rise to a disease, which is a general term or general entity. Now this particular chordoma, where these notochord tissues are there and growing in abnormality and giving some disease, most commonly seen in the nose area, we call them as nasopharynx. So we call them as nasopharyngeal chordoma. It can remain into the lumbosacral region. And this particular lumbosacral tumor, if it is present, we call them as sacrococcygeal teratoma. So what is sacrococcygeal teratoma? Abnormal tissue, which is a notochord tissue, which may be present, or primitive streak tissue, which is present. Now this particular primitive streak, which is formed over here, is representing in an adult form human individual in the lumbar or sacral region. The lumbosacral region of our body is basically where this particular primitive tissue is right now. So if we have a remnant of this primitive tissue present, cells there grow back and give rise to disease, which is a tumorous growth, benign or malignant. We call them a sacrococcygeal teratoma, which looks like this. So this is a common variety of these newborn tumor. Newborns are born like this. You are going to have an gynecological obstetric life in future. You are encountering this. This is a nightmare to deal with. You can have to imagine it's a big, huge swelling with a tumor with the baby. How are you going to do this? So we have to just like go for cesarean depending on this thing, right? So we call this sacrococcygeal teratoma, which is kind of most common tumor in the newborn. Females are more kind of like affected in this individual which are suffering from. So where from this particular sacrococcygeal tumor is coming, it's happening in the sacrococcygeal region, and residue totipotent stem cells of the Hansen's node or primitive sheath of the notochord cells, they can reach there, stay there, abnormally growing there, can lead to this particular disease. We call them as sacrococcygeal teratoma. It could be your exam problem. So what you have to understand, what you have to write here is that basically where from these cells are coming. Where from this particular notochord cells are coming and why this is abnormally present? What are the incidents in case of this particular tumor? In case of the male-female demographic pattern, it is male pattern more or female pattern more of the suffering of the individuals who are presenting with the disease that you have to mention. And you have to mention this is a common tumor in a newborn. And what is the treatment? So if this particular tumor is happening by here, earliest or soonest you resect it out or cut it out, has a good prognosis. The sooner it lands, you just like that, throw it out. Do the surgery and do relevant surgical correction. So sacrococcygeal tumor or sacrococcygeal teratoma, which could be a notochord or primitive sheath tumor, abnormal tissue growing in there and giving to this particular clinical problem. Second entity, rather more important to us out here is this one. This spina bifida, also known as NTD. This is the hot topic, neural tube defect. Now, what is neural tube defect over here? So we understand this particular vertebra. We understand the vertebra has got process. We understand the vertebra process has got arches, and it is holding around different parts and forming this particular intervertebra. Now this particular arching pattern of the vertebra, if that thing goes wrong, the processes are faulty developed that can lead to a disease. That series of diseases, we call them collectively as NTD or neural tube defect. Now basically it's a vertebral defect, but we are saying it as a neural tube defect, as if the neural tube has done something wrong, but no. That's what most of the time it happens in Indian citizens, right? You buy a ticket, land up in a train and proper booking, somebody will be coming without ticket saying, there is a strike in the train, you cannot go, please. Please, adjust कर लीजिए थोड़ा सा क्या करें गरीब आदमी बहुत neural tube defect. It's not a neural tube defect actually, but the vertebra, which is basically causing the problem, making this neural tube popped out, exposed to the surface, and we are saying neural tube is down. But we are not looking into that this is the vertebra which is the culprit and not forming and uniting properly, leading to this situation. So, how this thing comes about? We have three varieties, A, B, C. A variety is a least virulent or least kind of like a trouble. B variety, which is a moderate variety, and C variety, which is a great variety. You see this particular extent of this particular neural tube, which is basically coming out of the vertebra. So A picture, we call them spina bifida operta. So you see that this particular neural arch, which is going to form the neural spines in the back of this midline, that is deficient out here. But it's passed up by this particular tissue, subcutaneous tissue over here, and the defect is relatively less. Less defect is there. The spinal cord and this covering the spinal cord, which is known as meninges, is still in place. It's not coming out. Right? So this is a kind of like a variety which in a clinical it looks like this. This area which has a defect in the back side, there is a small hole in the spinal arch over here, we call them a spinal neural arch, which is deficient, and this particular region you see that looks like this, maybe just a little bit boggy or swollen out like this and nothing visible except this particular maybe patch of hairs or maybe hyperpigmented areas. Now compared to this one, which you see that D variety of the NTD, where you see that this particular spinal cord is there, but this particular meninges, which is popping out, bulging out, right? And it is coming out and making a visible elevation. This is the picture which you are seeing here. This particular individual is going to have this particular second variety of this. So the same problem, the bigger, wider the defect is there. The third variety, the greatest variety. You see that everything has moved out, spinal cord and this particular meninges with the CSF inside, in subarachnoid space, everything is out. So everything has come out and it is coming out. Every time the baby cries, the spinal cord and the neural tissue is coming out. The baby is feeling more and more pain because of this particular thing is coming out and cries even. So this is a common strategy which is having this particular problem with these three varieties of this. So what could be linked over here? This particular problem can be solved. How can it be stopped? By wearing mask, right? No, it can be stopped by wearing mask. So but still it can be prevented. Prevented how? This particular disease or this particular neural tube defect or NTD is linked up with the deficiency of vitamin E and folic acid, especially the folic acid. So once this particular family planning is there, once this particular couple decides to have a baby, you just like calcium and give this pill. It's a 5 paisa pill, folic acid, which is known as the folic acid supplementation. So this particular folic acid supplementations can prevent this particular formation of the NTD. Only 5 paisa saves a life. How many bucks you are losing then? So why you should give 5 paisa? I will earn the money operating on this, right? So it's a kind of like a poor trade for me. But still, it's a kind of like a tricky thing about this particular thing, which cannot be just like a predicted here. But this one, spina bifida, can be prevented by administering folic acid and holding on some drugs. There are some drugs which is known as the seizure drugs. Some people suffer from seizure disorders. We have a drug to control the seizure. We call them as that valproic acid. So valproic acid is again linked with this particular NTD. So we are not really to prescribe those drugs in case of like expecting mothers. We have to prescribe with cautions to the female subjects who are with that age group around that particular family planning age group. Right? So cutting down the medicine and giving on medicine, it saves this kind of problem of this particular problem. So So this particular thing together kind of gives us. Now neural tube defect, again, it's a very high in short note. The problem of this neural tube defect is the defect of which component of this tissue? Vertebral component disease or neural component disease? Vertebral. Then vertebra, which component of the vertebral precursor is causing a trouble on this? Where from the vertebra is the form? Mesoderm. Which part of mesoderm? Paraxial. Which part of the paraxial mesoderm? Medial part. Which part of medial? Scleral. So eventually you are a kind of like alright, I understand. So one piece at a time. Alright, so this is about the neural tube defect. You learned it how to hold it and you learned it how to teach it. The neural tube defect entity. So this is the summary of these things, whatever you have learned. So make sure you understand these components, whatever things we are going to learn.
So the slide would be shown over here and same slide would be depicted in the microscope. You have to identify and you have to write 3 points about it. Okay? Because already next class schedule is for cartilage, which has already covered, right? So next class would be for the granular epithelium on the next Saturday. Okay? So today we will discuss about the epithelium and the cartilage one by one. You have to, so please write it down, your name, roll number over there.
Gastric cartilage. ये देखो ओह
ভিডিও করে